welcome to the deep dive. Today we're really getting into a set of revision notes here. They're excerpts from the Comprehensive Review of Deafness.
That's the plan.
Think of this as your high-yield shortcut. Our job is basically to pull out the absolute key takeaways, giving you a really solid understanding of hearing loss and deafness straight from these notes without getting bogged down.
Exactly. And these notes, they cover a lot of ground. Starts with the basics, the definition, goes all the way through to, treatments, complications. We'll guide you through it, focus on what's really essential in this material.
Right, we're sticking just to what's written here.
Precisely.
So if you're looking to quickly get a thorough handle on the essentials of deafness, maybe for revision or just interest, this is for you. Let's unpack it. Starting right at the beginning.
The definition.
Yeah, the basics. So what exactly are we talking about when these notes say deafness or hearing loss?
Okay, so the notes define it as hearing impairment. Basically, it's a partial or complete inability to hear sounds, and it can affect one ear or both. A really crucial point right at the start is that it can be congenital, so present from birth, or it can be acquired later.
Right, so when it happens, matters a lot.
It really does. Changes the whole picture sometimes.
And the notes give us ways to measure this, right? Decibels, dB. Normal hearing is 0-20 dB threshold. What does that actually sound like?
Yeah, they give some good comparisons, makes it less abstract. A whisper, that's around 30 dB.
Okay.
Average home noises, maybe 50 dB. And conversational speech, like we're having now, roughly 60 dB.
So 60 dB is pretty standard for interaction.
It is. And then way up the scale, the pain threshold is really high, like 140 dB. Think jet engine level.
Ouch. Okay. So the grading of hearing loss is based on that threshold where someone starts hearing things compared to that 0-20 normal range. Can you walk us through those levels? Super useful for revision.
Absolutely. They use dBHL, decibel hearing level.
Okay.
Mild loss is 25 to 39 dBHL. The notes say here you cannot hear whispers. You might struggle a bit in noise.
Right. Subtle but noticeable.
Then moderate, 40 to 69 dBHL. Now the notes state you cannot hear conversational speech without help. That's a big jump in impact.
Yeah, daily life gets tough there.
Definitely. Severe loss is 70 to 94 dBHL. At this point, you wouldn't hear someone shouting at a normal level.
Wow.
And finally, profound loss is over 95 dBHL. This means you can't hear even really loud sounds that might actually be painful for someone with normal hearing.
That really paints a picture of the different levels. Okay, the notes also break it down by type of hearing loss, not just severity.
Yes, this is fundamental, super important distinction.
What have we got?
First, conductive hearing loss. The notes mention this affects about 4% of school kids, often down to things like glue ear.
Ah, the blockage type thing.
Exactly. Sounds get diminished, quieter, because something's blocking the path to the inner ear. But crucially, the sound isn't usually distorted. It's like the volume's just turned down.
Good.
Then there's sensorineural hearing loss. Less common in kids, about 0.3% according to the notes. Here the issue is in the inner ear itself, or the nerve pathway.
So, not a blockage.
No. And the key here is that sounds are both diminished and distorted, like a bad radio signal. The notes stress that the amount of distortion isn't necessarily tied to how loud or quiet the sound is.
Interesting. Distortion independent of volume.
Right. And finally, mixed hearing loss, which is, well, just what it sounds like, a bit of both conductive and sensorineural problems happening together.
Got it. So understanding the dB level in the type conductive, sensorineural, or mixed, that's really the foundation here. Tells you severity and gives clues about the wear.
Absolutely. Essential starting point.
Okay, let's move on then. We know what it is. The next big question from these notes is why? What are the causes, the etiology, and who's more at risk?
Right. The why and who. The notes list a whole range of causes. There are genetic factors, things passed down in families.
Okay.
Prenatal infections during pregnancy like rubella or CMV can cause it. Complications during birth itself. Then there are certain medications, the notes call them ototoxic.
Toxic to the ear, right?
Right. Exactly. Exposure to loud noise is a big one. Work or leisure. Aging, of course, that's called presbycusis.
That's the age-related hearing loss.
That's the one. Head trauma can do it. And specific ear diseases are listed too, like otosclerosis, that's bone growth in the middle ear, or Meniere's disease, which affects the inner ear.
That's a pretty wide net for adults.
Right.
But the notes also break it down specifically for children, don't they? The percentages are different.
They do, yeah. It gives a clearer picture for kids. Genetics is the biggest chunk, about 40%.
Well, almost half.
Yeah. Then intrauterine factors, so problems during pregnancy, about 8%. Perinatal causes around birth time, that's 12%. Postnatal causes, things after birth, are actually quite high, 30%.
30% after birth. That is significant.
It is. And interestingly, there's a big chunk, 20-30%, where the cause is listed as unknown.
So lots of factors, and sometimes we just don't know. What about the risk factors? Do they just mirror the causes?
They overlap quite a bit, yeah, but they highlight vulnerability. So a family history of hearing loss points to that genetic risk.
Makes sense.
Loud noise exposure, again, obviously a risk. Certain medical conditions like diabetes or autoimmune disorders increase risk. Those ototoxic medications, again. Head injuries, advanced age. Specific infections are high-risk congenital rubella, mumps, meningitis.
Meningitis, yeah, that's a known one.
Definitely. Also neurodegenerative disorders.
Yeah.
And even smoking is listed as a risk factor in these notes.
Okay, so connecting this up. Knowing these causes and risks helps predict who might be affected and what might be going on if someone presents with hearing loss.
Exactly. It guides the whole process.
Yeah. So next step, the how. Pathophysiology. Where in the hearing system do things actually go wrong?
The notes explain it can be anywhere along the path. The problem could start in the outer ear, the middle ear, the inner ear, or even in the auditory nerve pathways leading to the brain.
So it's not like one specific part fails.
Not necessarily, no. It could be a problem with transmitting the sound waves, like we said, the blockage idea.
Conductive.
Right. Or it could be damage to the sensory hair cells inside the inner ear. Those are critical for converting sound vibrations into electrical signals.
That sounds like the sensorineural type.
Precisely. Or it could even be an issue with how the brain processes the signals it receives. The exact mechanism, the notes say, depends entirely on the underlying cause.
Okay, so it links directly back to the types we talked about. Conductive is transmission trouble before the inner ear. Sensorineural is damage in the inner ear or the nerve. Mixed is both.
You've got it. That's the core link.
It's fascinating how a problem in different spots leads to such distinct types of hearing issues.
It really highlights the complexity of the auditory system.
Okay, so if someone presents with hearing difficulties, you need to figure out the specific cause. The notes talk about differential diagnosis. What else could be going on?
Yeah, this is key in practice. What conditions look like hearing loss? The notes suggest thinking based on the type. For conductive loss, you'd consider really common things. Otitis media, middle ear infection, or maybe a foreign object stuck in the ear canal, or just earwax buildup.
Simple blockages, yeah.
Exactly. For sensorineural loss, the differentials might include known causes like damage after meningitis, or it could be more uncertain, needing further investigation. Mixed loss, obviously, you'd consider factors from both lists.
Anything else?
Yes, importantly, the notes also list central auditory processing disorders. This isn't about the ear hearing the sound physically, but about the brain's ability to interpret it. The reception is fine, the processing isn't.
Ah, so the signal gets there, but the brain struggles to make sense of it.
That's the idea. So the differential diagnosis spans from simple wax to nerve damage to brain processing issues.
You really have to cover all the bases. Okay, let's zoom out a bit. Epidemiology. How common is this? The notes give UK stats.
They do. Around 11 million people in the UK have some hearing loss. And, as you'd expect, rates are higher in older people. That presbycusis link again.
Makes sense. What about kids?
It's common in children, too. The notes say nearly 1 in 5 kids are affected by age 18. They specifically mention temporary deafness from eustachian tube issues and middle ear infections, glue ear being really frequent in childhood.
Glue ear is super common, yeah.
And congenital deafness, so present at birth, is about 1 to 2 per 1,000 newborns. The notes also flag congenital sensorineural hearing loss, specifically as a common congenital disorder, same prevalence, 1 to 2 per 1,000 live births.
Okay, so millions overall, and a significant issue right from birth for quite a few. Puts it in perspective.
Definitely.
So how does hearing loss actually present? What are the signs and symptoms someone might notice in themselves or that others might see? The clinical presentation.
Okay, general signs for adults include difficulty understanding speech, especially if there's background noise.
The classic party problem.
Exactly. Needing to turn up the volume on the TV or radio, visibly straining to hear, frequent misunderstandings in conversation, which the notes point out can lead to social isolation.
That's a big one.
Huge. And tinnitus, that ringing or buzzing sound, is also common.
And for kids, it must be harder to spot sometimes.
It can be. Symptoms depend on the severity and when it started. Profound sensorineural loss, over 90 dB, might be noticed early, maybe 6-9 months, if a baby isn't startling or responding to voices.
Okay.
Lesser degrees might show up later, Things like speech problems, delayed language, maybe behavioral issues stemming from frustration or difficulties at school.
The notes also mention possible physical signs in some congenital cases, right?
Yeah.
Stigmata associated with syndromes.
Yes, certain genetic syndromes that cause hearing loss might have associated physical features. And when examining a child, especially thinking about conductive loss, the notes say check for signs of glue ear serous otitis media and look for enlarged adenoids, adenoidal hypertrophy.
What would you see?
Maybe mouth breathing, or a persistent cough from postnasal drip related to those issues. Though the notes do add that wax buildup alone rarely causes significant hearing loss in children.
Good practical point. And an ear exam itself.
Yeah, it might reveal signs of chronic infections, issues with the eardrum, maybe a cholesteatoma, that skin cyst, or you might literally see fluid behind the drum.
Right. So once you suspect hearing loss based on these signs, how do you confirm it? What tests do the notes list for investigations?
There's a whole battery of tests described. For adults,
Yeah.
pure tone audiometry testing hearing thresholds across different frequencies. Speech audiometry checking understanding of spoken words.
Okay.
Tympanometry that checks middle ear function, eardrum movement. Otoacoustic emissions, OAEs. These are sounds produced by healthy inner ear hair cells, so it's an objective Cochlear test.
Like an echo from the inner ear.
Sort of, yeah. And auditory brainstem response, ABR testing, measures nerve and brainstem response to sound. Very useful for infants or difficult to test adults.
What else?
Imaging like CT or MRI scans to look at the ear structures and brain, and genetic testing if you suspect an inherited cause.
And for kids, similar tests or adapted.
Some are particularly suited for kids. The notes highlight ABR and OAEs again, as they don't require behavioral responses. Audiometry is used based on age and ability to cooperate. Tympanometry, too. Imaging, like MRI or CT, is important for finding underlying structural causes, and chromosomal studies can identify specific genetic syndromes.
It's quite a range, from behavioral tests to objective physiological measures and detailed imaging. Really trying to pinpoint the problem.
Exactly, a comprehensive assessment.
Which leads us nicely to management. Someone has hearing loss, what can be done? What options are in the notes?
The main goal, according to the notes, is boosting communication and quality of life. So the options are varied. Hearing aids are common, amplifying sound.
The obvious one.
Right. Cochlear implants for more severe or profound sensorineural loss where aids aren't enough. Assistive listening devices for specific situations, like in meetings or watching TV. Learning sign language is an option. Speech therapy. Auditory training to help make the most of remaining hearing. And counseling is important, too.
So definitely not just about making sounds louder.
Far from it. And for children, the management is described as really comprehensive. Support and info for families is key. Big focus on communication support could be auditory oral approaches, using hearing aids, maybe radio aids,
What are those again?
where, say, a teacher wears a microphone transmitter, sends sound directly to the child's hearing aid, cuts through background noise. Very. Or it could involve cochlear implants, lip reading, British Sign Language, BSL, sign bilingualism using both sign and spoken written language, or finger spelling. Lots of communication strategies.
And educational support is mentioned too.
Yeah.
Plus specific management for conductive loss.
Yes. For conductive loss, often medical or surgical options, grommet insertion or adenoidectomy, especially for glue ear, hearing aids if the loss persists, autoinflation, that balloon thing might be tried for middle ear fluid, and surgery for issues with the middle ear bones or cholesteatomas.
The notes dive a bit deeper into hearing aids as well.
They do. Mention externally worn ones behind the ear or in the ear styles. They distinguish analog versus digital aids, noting digital usually gives better sound quality. And they list implantable aids too. Cochlear implants for severe to profound loss, and bone-anchored hearing aids, BAAs, for certain conductive or mixed losses.
BAAs use bone conduction.
Exactly. Bypass the outer and middle ear. And the notes also list other helpful equipment,
Right.
hearing loops in public spaces, vibrating pagers, visual alerts for doorbells or fire alarms, special phones, things to help navigate daily life.
Okay, comprehensive management. Lastly, let's look ahead. Prognosis, the likely outcome and potential complications. What do the notes say?
Prognosis, they state, varies hugely. Depends on the cause, severity, the individual. Conductive loss is often treatable, maybe resolves itself. Sensorineural loss is frequently permanent. But, and this is stressed, early intervention and proper management can really improve outcomes, regardless of the type.
There's a specific note about glue ear prognosis, isn't there? How that temporary loss behaves.
Yes. For otitis media with effusion, glue ear, spontaneous resolution within 3 months is common. But it can persist in quite a few kids, 25–60%, especially under twos in winter, or if they have recurrent infections. The notes really hammer home that identifying permanent loss early is critical for language, speech, and emotional development.
And for congenital sensorineural loss treated with implants.
Early cochlear implantation, ideally before 12 months, is noted as aiding typical auditory development and having a positive link to better language outcomes. Prevention gets a mention too, rubella vaccination, treating meningitis quickly, careful use of ototoxic meds.
So early action is key across the board. But what about complications if hearing loss isn't managed well, or just the impact it has?
Yeah, the complications can be significant. Communication difficulties are obvious, but the notes link this directly to social isolation.
That makes sense.
It impacts school and work performance, reduces overall quality of life. There's an increased risk of accidents mentioned not hearing warnings, and psychological impacts like depression and anxiety are common. Regular monitoring and support are vital.
And for children, the notes emphasize the personal, educational, social impact. Needs a holistic approach educating families.
Absolutely, for a fulfilled life. Oh, and there's that crucial safety point about meningitis and cochlear implants.
Right. What was that again?
Cochlear implant users have a slightly higher risk of bacterial meningitis. So the notes state clearly, recipients must be immunized against pneumococcal infection, check status, vaccinate before implantation, non-negotiable.
Got it. Important safety net. Well, that really feels like we've unpacked these notes thoroughly. From definition and types, through all the causes, the how and where of pathophysiology, the differentials, how common it is, how it looks, the tests, and the huge range of management options right up to prognosis and complications.
Yeah, we've covered the full spectrum laid out here. I think the key things that jump out are how crucial the type and location of the problem are for diagnosis and treatment, and just how much impact early intervention has, particularly for kids.
It really does highlight that hearing loss isn't just one thing. It's complex, needs a multifaceted approach, considering everything from the medical side to education and social well-being.
Which brings us to a final thought, something for you to maybe mull over based on everything we've discussed from these notes. Given the sheer variety of causes, from genetics to noise exposure to infections, and the really profound impact hearing loss can have on communication, learning, and connection throughout life, how can we as a society get better at ensuring hearing loss is caught as early as possible in everyone, and that the right kind of support is actually available and accessible for every single person who needs it?
That's a big question. Definitely food for thought. We really hope this deep dive has helped solidify your understanding, giving you that high-yield takeaway straight from the notes.
And if you're looking for more resources, especially for revision, remember to check out PassThemMSRA.com.
Lots of useful stuff there. And you can find even more materials over at freemsra.com.
Thanks for joining us for this deep dive.
Until next time.